Okay, everybody, we're going to get underway. I'm speaking into the microphone because this is a hybrid session. We do apparently have 40 odd people online, so welcome to those of you online. There's a camera up there. That's why I'm going to be looking in this direction sometimes. For those of you that have come out in person, thank you. And there is food here, so please do partake. For those online, if you're in the building, you might want to come down because there's food here. And so you can take part. I'll do a quick welcome and a quick introduction of our speaker. My name is Warren Mabey, and I am the director of the School of Policy Studies. So welcome here for this session. Before I start, I'll just say quickly that we are on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. And it is a privilege for us to be able to work here and to play here and to study here, to learn here. This has always been a place of gathering. Cataraqui has always been a place of gathering. And I'm glad that a few of us were able to gather in person today and hopefully many more online. Today's talk is an important talk. It is looking at the state of emergency medicine and talking about the state of emergency medicine, Canaries in a Coal Mine. Our speaker is Professor David Walker, who is the former director of the School of Policy Studies, former dean of the Faculty of Health Sciences, a practitioner of emergency medicine, and someone who knows a lot about these issues. We're delighted to have David here with us, and please join me, those of you that are here, in welcoming David to the session.
Thank you, Aaron, and welcome everybody. I hope the topic did not deter too many people from either attending emergency departments or this talk. I will speak slowly, but I use at my advanced age these slides to say. I was about to make a couple of acknowledgements. The first is that while I spent 3 decades of my career working in the emergency departments of our tertiary care hospitals, I do not any longer. And so it's with a great sense of humility that I speak these words about this topic, on this topic. The other acknowledgement I'd like to make is that for the most vulnerable, this is a very, very important topic. I will not speak specifically to the marginalized and those who are most vulnerable to this social safety net failing, but I would say that it is critical to keep in mind that our Indigenous peoples, those who are impoverished, those who lack housing and are housing challenged, those with addictions and mental health issues are most particularly affected by dysfunction in this important social support. I have no particular financial conflicts or other conflicts other than to say that I do have a conflict in this, and students know we teach you all the time to try to distract yourself from too much advocacy and passion in your public policy development. I'm going to probably fail at that. So if you see me become a little excited, it's because I am. So in the early days of coal mining, we all know the story. Canaries being particularly sensitive to noxious gases, canaries were taken down mines. And when they did this, it was an indication that there was a problem. And that's what I'm going to talk about. How am I going to approach this? I now live in 2 worlds. One is the medical world, the other is the policy world. And one might think that those were completely different worlds. However, courtesy of Keith Banting, who advised me and mentored me when I became more involved in health policy over the last couple of decades, he pointed out to me that in framing a public policy challenge, it was actually entirely parallel with what I've done all my life when faced with a patient. In the policy world, you say, what's happening? In my medical world, what's the problem today? In the policy, is it truly a problem? Medically, how bad is it? Policy world, what's the cause? We say, what's the diagnosis? What are the policies that we might have, use, modify, or create to address this problem in medicine? What are the remedies we have available to us? In both cases, what evidence do we have to support the options that we might institute? We talk about evidence-based medicine. I've always thought that was a strange term. I don't really believe in non-evidence-based medicine, although there's some magic out there. And then in the policy world, what are the ramifications of instituting a certain policy? And in medicine, what are the risks and benefits? And of course, critical to both is the results. How do we measure success? So what is happening? This is what's happening. This was a picture taken at Kingston General Hospital, the KGH site of Kingston. You think is a tertiary referral center for about 500,000 or 600,000 patients in the region. And in the middle of the day, so relatively quiet time of day. For those of you who do not see Adrian Arsenault's CBC room on the brink, this was the KGH site down the street. And here's Monica, who I've known for decades, having to close a section of the emergency department because of lack of staff. In other jurisdictions, a similar story. This is BBC News the other day, record number of nurses quitting the National Health Service. And then, of course, you add in this little virus that happened to be my test strip a while back. It's a bit chilling when you see that second bar appear. And I thought I was tired, but I had a good excuse. So the next question in that list I showed you of the parallels of medicine and policy, is it truly a problem? How bad is it? I don't think anyone can dispute. Patients, their families, and the public perceive that there is a big problem. The various professions and institutions in healthcare also state the same. Catherine Smart's president of the CMA, Canadian Medical Association, says what's clearly coming is the collapse of the current healthcare system. Duncan Sinclair may be online, I suspect, and I can feel a tremor because he will have reminded me we don't have a system. We noticed recently, just locally, closure of an emergency department in Perth. Imagine being distressed about your sick child at 10 o'clock at night, driving up to the Perth emergency department, and there's a sign on the door, closed. We did the same at our urgent care clinic, Hotel Dieu. We've shrunk it to numbers. Once 120 people have registered, the door closes. In the media, we see this every day, and I particularly follow Andre Picard, who is a superb health columnist and understands more about this than many. So I think we could conclude there is a problem. As Keith Banting would say, there's a problem and it's a big one. These are some numbers about emergency department usage pre-COVID. The previous 7 years increases by 44% in high acuity patients, meaning sick people who are actually seen and discharged, and 17.5% increase in people admitted. And you can see it took a little while to get things done. And it's only now are volumes approaching pre-COVID levels. Now, don't get spooked by this slide. I will return to it, but it is illustrative in a variety of ways. These are numbers about emergency department attendance in Canada, and they are for 9 months last year. Developed by what we call NACRS, which I think is a lovely acronym, the National Ambulatory Care Reporting System. It sounds like some sort of horse race track in England, NACRS. And it's broken down by province. It's broken down by acuity. That is how serious a person's problem is seen as they enter, which is obviously not the same as when they finished. And that uses a scoring system I'll describe in a minute. It's broken down by whether patients are discharged or admitted after their care, and how much time they spent with the experience. And the line I draw your attention to at the moment is merely the bottom one, where you see that in this 9-month period in Canada, there were 10.7 million patients who were seen in emergency departments. This CTAS level 1 to 3, those are the more seriously ill appearing as they appear. And 5 million in that category The 4s and 5s are less serious, 3 million there, and 1 million admitted. So about 10% of the people appearing in this time period were admitted to hospital. I'll get into the timing of stuff a little bit later. So what do these CTAS scores mean? We talk about it all the time. Level 1, of course, is you come in probably without vital signs or losing your vital signs. Which would be level 5. We do have a lot of information. This is a screen grab I took 2 days ago. This is real-time activity in Ontario's emergency departments. I just happened to just pick this one. And this was at noon, and this is real-time. So in the last hour, this is what was going on. Number of patients in the last 24,000. Number of patients in the last hour, 1,000. 156 hospitals reporting, and a breakdown of the various identifiers of age and seriousness and so on, how they got there. So we have no trouble knowing what's going on, and it's real time. I didn't take one in the evening when it would have been different. And we have surge measurements based on how close to your absolute max surge capacity are you. And more particularly at this particular moment in time, you can see that the more serious cases, the CTAS 1s, 2s, and 3s, represented about 70% of the patients presenting. The less urgent 4s, and then actually very few that were considered an unnecessary visit. So what's the cause? This is the next stage. You've got a problem. I understand that it's quite significant. What's the diagnosis? So let's go back to these numbers. 10.7 million visits in this time period. 5 million of the more seriously appearing patients discharged, 3 million of the less serious discharged, and 1 million admitted. So can we come up with a hypothesis as to cause of the problem here? You might say these 4s and 5s, the less serious folks, are overwhelming the system. And you might say that in the 1 to 3s, the more serious cases, most of those are discharged. So maybe they could have been seen somewhere else. It's sort of an intuitively attractive hypothesis, but there are some factors. I think we're all appreciating now that there's a particular issue with primary care and access to family medicine or nurse practitioners. They are finding it difficult to keep up. After hours, they don't have access to labs or imaging, generally speaking. And there is a profound growing disinterest in this career amongst medical students. So there's an issue here. Many are retiring in family medicine. So access to a family doctor is becoming highly problematic. And I would argue, and will again as we go through this, that absent a structured and effective primary care system, all else is going to fail. We also have tremendous issues with addictions and mental health, which would be a topic for another day. The patients who are addicted or have mental illness are those that find access to care highly problematic. I saw on the news last night that 6 more poor people died in the Belleville area of opiate overdoses last week. This is a tremendous burden. We also have a confounding factor that in Canada, home and community supportive care for the frail elderly is impoverished. We spend less on social care per capita in Canada than any other OECD nation, less even than the Americans, and we always use them as a comparison and say we're better. And we have this burden of very sick patients coming to emerge with late stage disease we've never seen before, probably courtesy of COVID. What would have been a trip to emerge 2 years ago with a little chest pain identified as cardiac cath stent put in is now presenting 2 years later in heart failure because they didn't go then. That's an example. So all in all, we must conclude from a policy perspective that there is an input problem. Maybe people there in emerge who should be somewhere else. So there are some policies we could use to address this. As I mentioned, reconstruct the primary and preventive care delivery model. I've always thought it strange. My son and daughter-in-law and 2 grandkids moved back to Kingston from Vancouver last year. And seamlessly, the children were absorbed into the school system. but not seamlessly into the healthcare system, where you're told, well, maybe years before you get a family doctor for the family. I thought, wouldn't it be odd if you moved to Kingston or Sarnia or White Rock, British Columbia, and you were told, oh, your kids are on the wait list for a teacher. It might be 2 or 3 years before you actually get them into school. We wouldn't tolerate that. But we now have a couple of million Ontarians without access to a family doctor, and that's going to get worse. So we need to address that. The demographics, I think a third of family physicians are going to retire in the next 15 years in Ontario, and there is great disinterest in the new generation in going into that. I do notice, intriguingly, that there are ways to get a family doctor. I only heard about this last night. If you join up to CAA Plus and corporate members receive 2 free general practitioner consults per year, and premier members receive 5 free general practitioner consults per year. And members can begin accessing the new benefit February the 1st, 2022. And my friend told me that membership in CAA has skyrocketed. I think this is one of the perverse effects. So I believe in and it would take radical restructuring. If you think restructuring parts of a university are problematic, try doing it in healthcare. There are models that work more effectively. The European polyclinic model with one-stop shopping to see a physician, a nurse practitioner, access to mental health services, physiotherapy, pharmacy, home and community care, and all of the other organizations that surround patients, including housing and employment with after-hours care. And this population is signed up. There's a comprehensive digital information system, and because of the 24/7 urgent care capacity, you don't need to go to emerge unless you're really sick. Say, on the other hand, I think if even in the worst case scenario, we reckon that 25% of patients might well be seen somewhere else. These low acuity cases actually utilize very little human and other resources in the emergency department. Those that are a bit sicker who get discharged usually require very significant assessment and treatment with resources that really aren't found elsewhere. And if you have a fishhook through your nose on a Saturday night, you're not likely to wait till Monday to see if your family doctor would take you. And there's nowhere else to go. And it's easy to do. So if you took the 25% away, you would not reduce the costs of humans and others that provide care by 25% by a long shot. And you can illustrate that by looking back at this slide. If you look at the CTAS 4s and 5s, here we are, and look in Canada, the median time spent in an emergency department is 2.4 hours. So that's pretty speedy. So would input diversion work? If we were to divert significant proportions of patients away, would that make the emergency department functional again? And I'm using KGH as an example, and this is real-time stuff. 46 emergency room gurneys in this large emergency department that serves a whole region for an average of about 142 visits per day. That was 2021, and remember that was a lower year than this year. On any given day, about 20 of those beds are occupied by admitted patients. These are people who've been seen in emerge, been deemed sufficiently ill to need admission to hospital, but they're waiting for a bed upstairs. So 20 of your 46 beds are filled. You can't use them. Nurses are looking after them and others. There's also the issue of staff shortages, as we saw in the Adrienne Arsenault report, and that limits capacity. In this particular story she showed us on CBC, they had to close a whole section of the emergency department because there were not enough nurses. And then I showed you the slide of the ambulances waiting to offload patients. You can't offload a patient into the emergency department from an ambulance if there's no nurse and no bed. So if you go to the emergency department, you'll see the ambulances lined up and the paramedics lined up with patients on their stretchers waiting to come in. And that leads to a very chilling situation that occurs in the province from time to time, code zero. Code zero is when an area has no ambulance available. Meaning if you flip your car on the highway, there isn't an ambulance that's ready to come and get you. And that happens in Ontario. And in this setting, which happens regularly. The chief of staff, Mike Fitzpatrick, will send an email out saying, we're on life and limb, Emerge is overwhelmed. Therefore, people from the region who need our tertiary care services come to Kingston. We put Emerge on critical ED occupancy alert, meaning all the functions of the hospital then subserve getting the patients out of Emerge upstairs. Surgeries are canceled or deferred. This slide. And look at the median time for admitted patients in the emergency room. It's 12.7 hours. There it is. So of this 10 million people, these are the admitted patients. 50% spent less, 50% spent more than 12 hours in the emergency department. Now, Ontario uses another very neat measurement of effectiveness. This is so that Ontario doesn't have to compare its performance with other provinces in a meaningful way. But as you know, the 90th percentile means that for the 9th out of every 10th patient waits in Emerge for a bed upstairs for 38 hours. This would be grandma with her fractured hip or abdominal pain in Emerge on a gurney for 38 hours. And in some provinces, 76, 50, 46. And I can tell you, if it's your family member who is in a corner of Emerge waiting to go upstairs, let alone not being able to get people in the door of Emerge, you get very frustrated. And if you're frail and old, you immediately get confused. You wet the bed, you haven't been fed because they're too busy to feed you, and you start to decondition very rapidly. So why is that? Why do we allow this to happen? What's going on? One of the facts is that acute care hospitals in Canada run at or over full capacity. We got into lean technology, the Toyota model of lean functioning. So running it just at capacity or over, it's the most effective use of resources. It was argued you don't want to have unused resources that cost you money. So we have 2.52 beds, acute care beds per capita in Canada compared to what you see there. A couple less than us, Sweden, about the same as the UK, far fewer than Germany, France, Australia. And of course, in our hospitals, as we read in the paper all the time, somewhere between 12 and 18% of our acute care patient beds are occupied by folks who no longer need to be there. These are called ALC, alternate level of care patients. Whatever it was that took them to the hospital and required admission has been either addressed or dealt with, and they no longer need that level of care. And they're waiting now to go somewhere. Home preferably, but Canada and Ontario provide so few resources for home care, that's problematic. You might get 3 hours a week. Rehab care, a wait list. Transitional care, a wait list. Or the famous long-term care, where capacity is limited, and after COVID, many people don't want to go to long-term care. Some patients categorized ALC remain in acute care for as long as 1 year. A friend of mine was in hospital a couple of years ago. I visited him, and the patient in the next bed had been there for a year. Nobody really knew why he was there. He didn't know why he was there. He was a bit confused. Nobody visited him. He wasn't getting any active treatment. He'd been in a tertiary care bed for a year. If you think that the average person having a hip replacement might be in hospital for 2 or 3 days, you could put 100 patients through that bed in a year. So the result of this phenomenon is that functional hospital inpatient bed capacity is reduced. Regular hospital services are constrained, wait lists extend. The emergency department holds admitted patients awaiting a bed, so you don't have much capacity in Emerge. It becomes overcrowded, becomes dysfunctional, care becomes jeopardized, access is blocked. Patients and families quite rightly become frustrated, violence is common, and the staff get burned out and some quit. So we must conclude that there is an output problem that requires mitigation as well as an input problem. And there are ways to do that. Obviously, reduce the number of people who become alternate level of care by various means. And this is a thorny, difficult problem. But clearly, better primary and preventive care of the frail elderly in whatever setting. significant investments in home care, community care linked to health teams, as they do in Nordic countries like Denmark, more transitional care centers. We have one here, using long-term care in a different way than we do now, linking long-term care to hospitals. And another, I won't get into this very much, but an idea that is done in other jurisdictions is to decompress hospitals laterally with ambulatory surgical centers. There's no actual reason why you need to have your cataract or your knee replacement or your endoscopy in an acute care hospital. You can have it done in a unit nearby using the same medical and nursing staff, but outside the hospital setting, so that surges back and forth in the hospital activities due to flu outbreaks or COVID outbreaks don't influence the ability to continue providing this care. Then, of course, you've got the input problem, the output problem, and then what about inside the emergency department? Can function be improved? In fact, looking at it in a biased fashion from the inside, the actual functioning of the emergency department is remarkably efficient given the constraints imposed from outside. The biggest challenge at the moment, other than those I've identified, is health human resources. And we do need a different approach to this. And it's a topic that we could go on for a long, long time. In particular, nursing. There's not so much of a problem with physician availability to work and emerge, but nursing there is. There are some very strange, perverse internal marketplace issues. A nurse that's had 5 years of experience working in ICU or the emergency department will see posted a job opening working in the clinic at Hotel Dieu. Same pay, day work, weekends off, nights off, compared with working in the emergency department, shift work, double shifts, same pay. So this is a collective agreement issue that in part might have some effect. There are obviously other things to do, fast track those less serious cases, link digitally better to primary care. It's very difficult to link health records at the moment. We need a completely different approach to addictions and mental health issues. And we need some public education. So, policies and prescriptions, much the same idea. And if these are prescriptions for the emergency department, they are clearly prescriptions for all healthcare delivery. I would argue that we, as I alluded to earlier, we need to develop community health hubs of integrated primary care providers who are accountable for the care of a population with 24/7 capability, and link that to the home, social, and community care programs to maintain health at home. The ambulatory surgical centers I mentioned, I think, are a good idea and have been shown to be effective in other jurisdictions. We need to reduce the length of stay of our ALC patients and provide alternatives to that. We certainly need to address the health human resource challenges clearly before us. We need to digitize. We still use fax machines. It's remarkable how much they can go awry. One digit wrong and your fax goes to Shoppers. Instead of going to Shoppers, it goes to Home Depot. And more than anything else, we need some authority that imposes accountability for performance in our system. And that will decompress the emergency room. The policy ramifications. It's said that healthcare is the third rail of Canadian politics, that no politician will stand up and admit that healthcare is in crisis because that reflects on them. Not only that, they have a life cycle of 4 years usually, and there are ways to actually nibble around the edges, open a new this or that with a ribbon, and not address the fundamental, very, very difficult task. An example being that we have thousands of primary care practitioners in Ontario who can work wherever they want, whenever they want, in whatever way they want. And there's no accountability for deploying that resource to address the needs of our society. The disinterest in family medicine is so acute that I know in one family medicine training program out west, which produces dozens a year of family physicians trained, none went into comprehensive family medicine. They go to work and emerge, they do locums, They go into palliative care, they become a hospitalist. They don't go into family medicine and provide comprehensive GP work as we all understand it. The interest in the graduating classes across Canada in primary care have falling like stone. So the political arm of this, because Canadians continue to believe that we have a really good healthcare system. At poll after poll after poll, so how do you identify yourselves? What are the values of Canadians? What's special other than hockey? We try to be best at hockey, but we think we're best in healthcare. But that's only because we're slightly better, perhaps, than the Americans. And I'll show you a slide about that in a minute. So I think we need to convince the public first, because until we stand up and say to the politicians, we really won't tolerate this. I cannot tolerate my mother being on a gurney for 30 hours in a merge when she's being admitted to hospital. With all of the beeping and the noise. And I tell you, I don't know how many of you have spent 30 hours without sleeping. I'm sure many students do this from time to time. When you're 75 or 80 and somebody doesn't let you sleep for 2 cycles, you go really weird. And that's not fair. I had hoped that COVID was a burning platform, which would have shone the light that woke us up. But I think we diverted into being so fearful of COVID that we've gotten sidetracked onto the COVID bit rather than the fundamentals. It was a light that was shone. Showed how the marginalized in our society were even more impacted, as I alluded to at the beginning. So that's the first thing. But pilots are lovely, but they tend to end and then we don't scale them up. But there are all sorts of really good models that could be utilized. We certainly need to make primary care reform a priority. If you're going to encourage the development of polyclinics, you might need the private sector to come in and help build some buildings. That's not private medicine. The private sector builds hospitals. Your current family doctor's office is owned by someone. It's not owned by the government. It's probably owned by your family physician, actually. So we need to incorporate some private sector component to this so that we can actually develop centers where people can go to get care. And that will decompress the emergency department. And when you talk to young physicians about primary care, one of the things they say is, look, if I go and become a cardiologist, I don't need an office. I'll just go to the hospital every day. I'll do my stuff. They provide everything. And then at the end of the day, I come back. I'll be on call 1 night a week. I don't have any administrative burden. If I go into family medicine, I've got to go find, a building. I've got to buy one or rent one. I've got to actually then employ staff. I don't know how to hire people. They'll need a contract. I've got to pay benefits. I've got to worry about the roof leaking. I've got to buy a software system. I've got to, work out how to schedule patients. It goes on and on and on. They say, I don't want to do that. That's not what I trained for 10 years to do. I want to just go to work and look after sick people. So we need to think about that because it is a profound deterrent to going into primary care. My dad was a GP decades ago. He just loved the fact that he and some buddies built a building and put their practice in it. And they'd spend evenings drinking beer, working out, the budget for this and that. Loved it. Get a pharmacy in there. This generation of young docs don't want to do that. So instead of going to family medicine, let's go, I'll be an anesthetist. 4 years of training, it's only 1 year more. I get paid better. No cost of administration of my practice, it's provided for me. So again, there's a perverse disincentive in our system that needs addressing. And I said the turnkey operation model is clearly going to be, and in fact, I've spoken to many ministers of health and said, the other thing you can do if you want to drive people in certain directions in medicine, offer a pension to young physicians. We offer pensions to other public sector employees. Offer them a pension. It won't cost your government anything for 45 years. But I'll tell you, if you offer a pension to someone to go and work in a new model, my guess is they'll go in a flash, provide parental leave, sick leave, holiday, conference time, and a pension. You'll see a whole generation of docs go in that direction. They thought that was amusing, but didn't do anything about it. And I would argue again, don't just throw dollars at this. We see the provincial premiers arguing with the federal government, give us more money and it'll all be okay. Well, Paul Martin gave 10 billion or something to fix healthcare for a generation. All that happened is in various provinces, the nurses and the doctors negotiated better pay. And that was the end of it. Did not lead to any restructuring. So don't throw money at it, but link funding, I would say, to performance. And for goodness sakes, let's invest in social care. We are a laggard in that regard. So the last thing about prescribing a pill or a policy is, how do we know if any of these things will work? The Commonwealth Fund produces this every year. You can argue about the criteria, you can argue about how they measure it, but it's very consistent. And it shows that every year, Canada is 10th out of 11th in terms of health system performance. I don't think Canadians quite figure on this, other than the fact we're better than the Americans. So, well, if it's better than the Americans, then aren't we good? I think 2 years ago, we snuck up to number 9 because I think France had a problem and fell down. They lost their goalie and so they couldn't win anymore. But we tend to rank 10th out of 11. And if you look at value for money, this is a very interesting slide. On the left, you see health system performance, higher healthcare spending, lower healthcare spending. So we spend about the same, if not a little bit more than most of our partner countries, other than the States, of course. But in terms of performance, we are way down. That's a bad place to be. So we need better value for money. And if we get better value for money, the Canary will thrive. Happy to answer. Thanks to my team.
Thank you, David. I'm going to take over for Warren.
Yes.
Just because we've got questions from the audience as well as questions from the Zoom. So we're just going to stop the share here.
Question. Happy to answer any question.
All right. So I've got one actually that someone has texted me. To what extent has COVID made the situation worse? Will fading of that pressure on patients and staff help mitigate some of the strain?
Say the back part of that again.
To what extent has COVID made the situation worse? Will fading of that pressure on patients and staff help mitigate some of the strain?
Yeah, well, COVID has clearly had a variety of effects. In the first instance, for the patients, there is clear evidence that so many people did not get the care that they were expecting, often scheduled to receive, let alone the preventive maintenance side of this. So I think in every healthcare setting, we're seeing this backlog of delayed appearance of disease or missed interventions. And the bizarre, Chris Simpson was speaking recently at the Sinclair lecture. In fact, some of the predicted numbers of people who would come out of the COVID era haven't even appeared yet. So the predicted numbers of people coming out for care that you would have expected to get back to normal missing. So there are hundreds of thousands of missing patients. The referrals to regional cancer centers is very steady. To KHSC's cancer centers, to Princess Margaret's, wherever you are in the country, the referrals for cancer to these cancer centers is very steady. It goes up a bit every year, but it's very steady. During COVID, it went down. Now, the incidence of cancer has not changed. It's not disappeared. COVID did not scare cancer away. And you'd expect it to have come back with a bulge. Well, it has come back, but the bulge is not as big as it should be. There are people who are sick who don't know it. I used the example, I think, of someone who had chest pain and should have had a stent, but now presents with heart failure 2 years later. So COVID has had an effect there that will linger. I think it's fair, very fair to say that the effect on healthcare providers has been profound. And it is disheartening to have gone through 2.5 years, let alone when people were demonstrating outside the hospital for some reason and yelling at nurses. There is an exhaustion there from having to worry constantly about your patients, the fact that you could contract a disease and take it home to your family, and now knowing that we've got more work than usual to do to catch up with everything that wasn't dealt with. So we've got it. This is one of the reasons that Health Human Resources is really in trouble, is that people are really tired, particularly in the hospital setting. They're exhausted. And I think Adrian Arsenault pointed that out. The fact of the matter is COVID's not gone away. We are very well protected by vaccines. There's no doubt about it. But the fact is that if you're a healthcare worker and you catch COVID for the first or second or third time, you're not going to go to work. And it is still circulating so widely, as you saw from my COVID test. So there is that as well. My third answer would be, as I said earlier, I would have hoped that the bright light that illuminated the shortcomings of our so-called system would endure in ways that would force us to make changes. The travesty of long-term care and COVID is a national shame. Canada's deaths from COVID are actually compare very well with other nations. We had tighter controls on restrictions on human movement, and that actually reduced the number of people who died. But in the early days, the number of deaths in long-term care was astronomical, and we've all read about the reports of the army after they've been into a long-term care facility, finding starving individuals lying in feces and urine for days with bed sores, unattended, and or dying and dead. So one would have hoped that that experience would lead us to a very rapid and radical addressing of the care of the aging and elderly. I'm at the front end of the baby boom. So my generation behind me is enormous compared to what we're dealing with now. We're the generation that saw temporary school buildings. We had grade 1A, grade 1B, grade 1C, grade 1D, grade 1E, grade 1F, because there were so many of us. So imagine as we get into our 80s and 90s, the number of people in their 80 plus is going to double in the next 10 or 15 years. So we're going to have to address the care of the aging population in a way that is radical, I believe. So COVID should have done that, and I hope it has. Andre Picard written about it. Everyone's talking about it. The Long-Term Care Commission examined it. The Auditor General examined it in Ontario. So there are three pieces to that, Chris. Yes.
Yeah, I have a question. First of all, thank you, Dr. Walker, taking the time speaking to us about such. Oh, sorry. Speaking to us about such an important topic. My question revolves around. You mentioned how that we need to convince the public of how actually our healthcare system actually is failing. But like, how would you suggest in approaching such a difficult topic as like us Canadians? Our healthcare system is so ingrained within our identity that even with COVID, like you mentioned, it's almost sidetracked us and like made us lose our focus on what is actually occurring within our healthcare system. So how would you suggest approaching such discussion towards the broader audience?
Well, I wish I knew the answer to that. It's a perennial challenge. How do you engage the public in appreciating that there is a social problem of significance sufficient that those that we elect will address it? So in the last year, we've had two elections in Canada in the two biggest provinces, in Quebec and in Ontario. Both led to majority governments, and in neither election was healthcare really mentioned. Which is surprising because Canadians say that it's important and they clearly believe that it's important. It is reality that at any given time, the vast majority of us, even old folks like me, are healthy. So we don't really think about it. I'm sure that from time to time you've gone to an emergency department, likely with something that's not particularly serious. You may have broken something and you say, wow, it's busy in here, you know. When you are either the 80-year-old who's lying there for 38 hours or the family member of that person, you suddenly become aware that there's a really big problem here. But that's the minority of people. When your grandparent needs to be admitted to long-term care, you suddenly realize this is a warehouse for the elderly, with poor everything. And this whole issue of who owns and runs long-term care is a whole other discussion, for private for profit, private not for profit, publicly owned. So I don't know the answer to that question. I think you just keep talking about it. I would have hoped that some brave politician will stand up. We've got a federal election coming along. Will the conservatives, there may be even conservatives like Hugh Segal around who says, this is a waste of resources to do it this way. From a conservative point of view, it's a waste of resources. Can we not somehow better value for money, which will be better value for the public? Or maybe the left wing will be brave enough to say, we're afraid the conservatives are going to win. Let's pick a topic that we believe Canadians really are attached to, and maybe whoever's leading the Liberal Party or the NDP will put this forward as a platform. We've seen a little bit of that. Pharmacare, I haven't seen it happen yet. Dental care, Jagmeet Singh says he's going to push through to do it, but he hasn't done it yet. These are all the bits of our healthcare that aren't covered by the publicly funded system. So I don't know the answer to that. What usually happens is we get so far down the pike that it really is another crisis. And then it takes a lot of forethought to fundamentally restructure the way in which we do things. Our healthcare system is beautifully designed for the 1960s. Worked really well. Young population, episodic care, occasional heart attack, lots of trauma, dislocated this, cut that, fish hooks. Old people did not live as long as they do today. When I was a young physician, if you needed chronic lung disease addressed or heart failure addressed, your life expectancy was months. And now it's many, many years. We are really good at keeping people going functionally very well. But that means, like an old car, it needs a lot of maintenance, a lot of attention, a lot of addressing. So it's a really big problem. And our healthcare system is not designed to fit the needs of today. We need far more social care, actually rather less true medical care. And it gets us all the way back to the social determinants of health. If you're unemployed, marginalized by whatever criteria, housing challenged, food challenged, you're going to get sick. You're going to ending up in a merge. Professor.
I'm one of the lucky ones. When we relocated to Kingston, we got into the Queen's Family Health Team, where we've received wonderful care from a large group practice close to our home. And Duncan Sinclair convinced me this was the model for the future. Is it not working, or is it not being rolled out elsewhere?
So yes, it is working. So the advent of family health teams by a previous government was the funding. So you would have, let's say, 4 or 5 family physicians who already had a practice together, shared a building, but they had their own patient load. And it was basically them and a secretary and a nurse. And they would pool their income to pay for the nurse and the secretary and the building. But it was appreciated that there were many other disciplines that needed to be involved in the care of patients, especially those with complex problems, those who are older. So the concept of the family health team that was stolen from other nations was to fund the allied professionals who would work with them. So a nurse practitioner would take over some of the load of the family physician. You'd have psychotherapists 2 days a week. You'd have a dietitian. You'd have linkages with pharmacies. So you'd have multiple disciplines. In many practices, a social worker, who invaluable and the government paid for those additional people. Because previously, if the doc wanted to hire those people, you'd have to bill a patient for seeing them and then use that money to hire someone who's going to see the next patient, but that doesn't bring in any revenue. So it was a no-go. So the family health team was very successful. I don't think they were successful in terms of accountability, in terms of after hours and weekends, but they were successful in wrapping care around patients, but it was more expensive, as you might imagine. Docs still equivalent. The government was paying for all these extra goodies. So they capped the number of family health teams, right? Leaving a very interesting inequity. So you go to your Queen's Family Health Team down there by Hotel Dieu, and you have access to all of these things on your OHIP card. But if you go to Dr. Jones up the street, who's in a group with 2 other docs that it's not a family health team, and you need one of those services that down the street they have, you'd have to pay for it. If you needed to see a behavioral psychologist, you'd have to pay for it, not in the other practice. If you needed a dietitian, you'd have to pay for it, not in the other practice. But they've capped the number of family health teams. One of the reasons young medical students don't want to go into family medicine is that they want to go into a family health team, but they can't get into one. So they're going to end up working fee for service down the street somewhere. They don't want to do that. So yes, it is clearly the right plan. And as we incorporate family health teams into Ontario health teams, which is the current plan, which is an aggregation of community service organizations, institutions, hospitals, long-term care, home and community care, long-term organizations. The hope is that rapid populations plan. I'm just not quite sure where the has to put in the tank to get us there is yet. But you're right. Duncan Sinclair was right. Team-based care is essential. Mostly because for the people who are frail and older, it ain't the doc they need to see, actually. It's the physio and the dietitian and the occupational therapist. And maybe a geriatrician drops by occasionally. That sort of thing is what's needed. So again, we've got a mal-design of the system. Yes.
Hi, Dr. Walker.
Hello.
Quick question for you. Would it be possible for you to elaborate a bit more on the role of preventative care in terms of addressing the ER situation? I know you also spoke about many times the disinterest in family medicine, and we obviously know that's a critical piece in preventative care, but I was just wondering if you could elaborate a bit more on that.
Well, absolutely. I mean, I keep thinking of the days when we've had Kieran Moore sitting here when we've done some of our previous talks, mostly about COVID, but wearing my public health hat, health promotion, disease prevention, some societies are better off than others. And there's absolutely no doubt that if you invest in helping the population adopt healthy practices, people are going to be sick less. Now, you're not going to stop the ultimate dying, but you can lower the burden and certainly square off that population curve so that one remains functionally healthy. And as things begin to get a bit creaky, as you get older, modifications can be made. And so that you do not overburden yourself, your family, or the hospital system, healthcare system, until closer to the very end, whatever that very end is. There are some confounding pieces to that. We don't understand yet enough about dementia and the fact that so many of the elderly population, partly by the fact they get so old, but develop a dementing illness, and that can be profoundly troubling. Your OHIP card doesn't really help you very much if you've got Alzheimer's disease, because what you need isn't really on the medically necessary end, right? You need someone to help in the house. You need someone to be there at night so you don't wander off. You need social supports, but we don't pay for generally. So you end up in a long-term care facility on the Alzheimer ward, which is, we don't have advanced directives for end of life for those who are demented. That may come one day. We don't, generally speaking, have end of life plans. But your point is that if we can be a healthier population, remember, you don't remember participation, and everybody was running 5K a day, and it obviously makes a difference to the individual. In the end, we're all going to get things go wrong. You're going to have to pay for that somehow. In fact, if you're too fit, you're going to be the one who needs the knee replacement. But no, I think any healthcare reform must be based on a platform of preventive care, preventive maintenance, and in particular, as one gets older. There are models elsewhere where as one gets into one's 60s, there's proactive interaction with your healthcare providers. We don't have a lot of proactive stuff here. Occasionally you get a message, do you want to come in for a flu shot? But we don't, generally speaking, get the messaging that it's time for your annual chat with the doctor to talk about your care for the next few years. We don't do that here very much. In Britain, interestingly enough, your first pension check comes with a fecal occult blood test to check for colon cancer. And so you get your check and you get your little kit at the same time. It was kind of cute, you know. Wow, very proactive. We don't really do that here. No, I couldn't agree with you more. And my generation, the boomers, we're pretty fit, but there are an awful lot of us. So even if a smaller percentage of us get really sick, Pat, that's an enormous number.
Hi, Dr. Walker. Thank you for coming here.
Thank you, team. I'm most impressed.
So before I get to my last question, I just want to make a quick comment.
Yeah.
My brother went to UBC Med School and obviously I've hanged out with his friends. And like you said, unfortunately, it has come to that. I've seen them talk. You know, they are kind of deferred from the family medicine. They talk about, you know, paying for the building, or if someone else owns it, then a chunk of their income goes elsewhere. They look up the professors, how much money they're making, and you know they want to go into plastic surgery or whatever. But yeah, so that is definitely something that the government needs to address. Unfortunately, medicine should not be driven by financial incentive, but it seems like something does need to be done in that. Just to address that. My question is, while you were doing your lecture, the Premier of Alberta, Jason Kenney, actually announced that they are thinking of releasing a plan to attract and make it easier for international trained nurses to come and work here. Do you think Ontario should implement something similar to do that with nurses as well as the family doctors?
Yes, no doubt. A health human resource planning scenario, internationally trained health professionals obviously are key. I think, I forget the latest number, but at any given time in Canada, a quarter or a third of physicians working in Canada trained elsewhere. So clearly that is a potential. I know that there were in the last few months somewhere between 5,000 and 7,000 internationally trained nurses in Canada, trying to get through the hoops of recertification. And clearly, some of them should be capable of going right into ICU. Some of them might need considerable retraining, rather depending on where they train and in what setting they train. You're not going to take someone who was working in a public health clinic in Indonesia and put them in a Toronto General ICU for obvious reasons, any more than you would for a Canadian public health nurse into ICU. So there is that issue. There's an ethical issue, I would argue, although I have all sorts of support for internationally trained physicians and nurses to be moved into our workforce. There is the ethical issue of denuding other populations of their prized possessions. Canada was highly criticized a few years ago because we actively recruited trauma surgeons and trauma nurses from South Africa. Actually, a whole team moved to a province west of here, leaving about 1 million people in South Africa without any access to trauma surgery. So there's the ethical piece of it. And lastly, we're a wealthy country. Our medical school at Queen's had 5,500 applicants for medical school last year, and we are only allowed to take 130. Now, admittedly, many of those smart people applied to 5 medical schools or 8 medical schools, I don't know, but nevertheless, you can't tell me that of the 5,500, that 5,370 were ill qualified to get into medical school. God, I mean, at least 4,000 of them, I mean, should. So, and the same true of nursing. Nursing schools have had applications skyrocketing. So we're a wealthy country. Why don't we train more? Cuba trains more physicians than Canada does every year and exports them. So yeah, internationally trained people, critical, especially in the next 10 years. But we should make our own. I think I'm over time.
Thank you, David. We are at the end of our time. There's lots of great questions. I think what I'll do is I'll just forward them to you, and maybe if you have a time in your very busy schedule, you can take a look at them. They're really good ones. This was a really great talk. We really appreciate you taking your time to come out and join us. We had a great audience online and also in person, very engaged. Thank you so much.
Thank you, Chris. And thank you, team, for being here.